All right, thank you. I'm honored to be here today. There are a lot of really smart people out there. Dr. Dixon, from a speaker's perspective, I heard they started with the smartest speakers first. I don't know if he's still here or not. So sorry for the guys that speak tomorrow. I'm going to talk today about interventional pain management for spine disorders. And it's a real sensitive and fun topic for me to present to you today. I get to work with a lot of you as we care for these spine patients, and I think the things we'll talk about today, hopefully I'll find more value, or we'll find more value for our patients as we go through these. What we're going to do today is talk about different types of spinal injections, indications for specific injections, and we'll go through some of those specific injections. I'll present some risks, some of the benefits and the successes of our injections, and then we'll talk about some post-injection recommendations. For most of our spine-related problems, of course, when we start thinking about injections, we're looking at ways to manage pain, and that's probably the most common reason that we do spine injections. We're also looking to improve disability, improve weakness, and for many of our older patients, to improve quality of life. I think another big indication for us in the world of injections or interventional pain management is for diagnostic purposes. And we work real closely with the surgeons in an effort to determine whether the patient's pain is coming from their back or their hip or their SI joint, or their back or their SI joint, their neck versus their shoulder, etc. And I think as physical therapists, this would also provide some really valuable information for you as you care for your patients. We glean a lot of real helpful information from the responses to these injections. For example, if you're working with a patient that has a rotator cuff problem along with the cervical spine problem, their response to an injection in their neck really would help us determine which mode of treatment to follow. If they get great response from a cervical epidural steroid injection of their shoulder pain, that probably tells us we're dealing more with a radicular problem, and vice versa. If they don't get good relief from a cervical epidural steroid injection for what we think might be a cervical problem, it's probably not coming from their neck. So we use these injections frequently from an injection standpoint, or from a diagnostic standpoint, sometimes directly, as that's the way it might be ordered, but otherwise indirectly. So we're always looking to evaluate their responses to these injections. And I would encourage you as physical therapists to use that as part of your history taking. When you see patients that have had injections, you really can gain some useful information when you specifically ask them what the relief from the injection was or wasn't. I think that provides a really valuable tool. Other benefits that we talk about with injections is that we can lessen the need for medication, and I think this is huge in our opiate crisis today. We wean patients off narcotics oftentimes by using periodic injections. We discourage the use of narcotic medications by encouraging injections if they're indicated. We can also reduce the need for other medications, and certainly all medications have potential side effects. So even the use of anti-inflammatory medications can be risky for patients. Some of the neuropathic pain medications have side effects that are undesirable. So those patients may have a higher indication to use injection therapy. Another real big, I think, benefit of injection therapy when it's indicated is to really improve the effectiveness of physical therapy. We work very closely with physical therapists. Many of you I work very closely with. And when what you're doing in physical therapy isn't working, or when you hit a roadblock with a patient, under certain circumstances, I think considering an injection is a very sensible option. And another option, or another benefit of injections, I snapped a picture of Dr. Dixon just before he was going into the operating room, is to prevent a surgery. So if we can keep patients out of the operating room, no offense, Dr. Dixon, but we can control a lot of the other risks and potential complications that may come with an invasive surgery. What do we inject? Well, most of the time, and most of the injections I'm going to talk about today will involve cortisone injections. And cortisone comes in different forms, and I've listed the names of some of the more common ones. They're all fairly similar, although some of them differ in the amount of particulate matter they carry. So in injections that may be closer to a sensitive vascular supply, we may use a medication like Decadron, which tends to be less particulate. But all in all, for the most part, steroids are used interchangeably and tend to be more user preferred. Usually most epidural steroid injections contain a component of a numbing medication, and usually that's a longer acting numbing medication like Marcaine. We use lidocaine on the skin. And then oftentimes we'll include some normal saline just to act as a flushing compound, or sometimes to increase the volume of the injection so we can cover more territory, so to speak. How many injections can patients have a year? That's a common question that we get, and a loaded question. And it's difficult to answer that with just one answer, because it depends on the patient's health, it depends on the patient's disease process, it depends on how many other comorbidities they have present. But all in all, the most logical answer, I would say, would be up to about 4 injections per year. In patients who are brittle diabetics or uncontrolled diabetics, or people that have kidney disease, or people that have congestive heart failure, we may give less injections. On the flip side, if we have a real elderly person whose only pain relief option for her is an occasional injection, sometimes we sneak an extra 1 or 2 in there for her to keep her active. How successful are epidural steroid injections? Most of the research will say generally that about 50% of the people get measurable improvement in their pain after an epidural steroid injection. I think this is arguable depending on which studies you read. Many of the studies don't consider things like how many levels are involved in the disease process, whether or not X-ray was used to do the injection, which is extremely important, whether or not the patient was a smoker, whether or not the patient was overweight, whether or not there were other issues involved, such as secondary gain issues. And I think if we eliminate a lot of those variables, most of the time in fairly straightforward spine problems in a non-smoker, otherwise healthy person, I think injections are a very good option for conservative care once other less invasive treatment options are exhausted. Who can't have an injection? There are some definite contraindications to injections, and one of them would be the presence or suspicion of any type of an infection. We certainly don't want to put cortisone into an area that may be infected. So in a patient where you have a suspicion for that, I wouldn't encourage it. People who have bleeding problems or on blood thinners cannot have injections. That doesn't mean we can't consider removing or taking them off their blood thinners prior to an injection, but they definitely cannot be anticoagulated prior to an epidural injection. People who are pregnant can have an injection. They just can't have it using X-ray. And depending on the stages of their pregnancy, they may or may not be able to lie prone in the typical position. So if an injection is indicated, it would have to be given without X-ray and with them in a sitting position, which is the way we used to do them. As I mentioned earlier, some comorbidities may make it more risky to have injections. So people that have uncontrolled diabetes, uncontrolled congestive heart failure, bad kidneys may not be a candidate for injections. Allergies to cortisone are extremely rare, but if it is truly an anaphylactic allergy, those patients should not have a cortisone injection. Probably a more common allergy is an allergy to the dye that we use during the injection. So if that's the case, then we would avoid using that dye. What are the risks? Well, the top 3 are bad risks. We don't want to see these, and I'm happy to report I've never seen an infection from an epidural steroid injection. I've never seen a bleeding problem that resulted in a serious complication, and I've never seen nerve damage. So those are the big 3 that would be catastrophic. A headache or a dural puncture can happen after an epidural steroid injection. It's more common after people have had surgery or in patients that have had prior low back surgery. It is a correctable problem if somebody gets a headache. One of your patients, you'll know it. It's the worst headache they've ever had. If the dura gets punctured and they get a spinal headache, it's a very positional headache. It's a headache that gets worse when they stand up and typically goes away when they lie down. And if that does happen, we actually do the same procedure, another epidural, but instead of injecting medication like steroid, we inject blood and do what's called an epidural blood patch. Another potential complication is a post-injection cortisone flare. In some patients, cortisone actually irritates before it helps. So patients may experience more pain for the first few days after an injection. And then typically once the cortisone starts to work, they feel better. Facial flushing, a very common complication or side effect, more so after an epidural steroid injection. People feel like they have a sunburn or they feel like they've been out in the sun, and they may actually look like it as well. That's a very normal side effect. Elevated blood sugars in diabetics can be a risky side effect, so we really encourage our diabetics to real closely watch their blood sugars after an injection and adjust their insulin accordingly. Other side effects include insomnia, fluid retention, and possibly some increased cataract risks. Just to quickly review the spinal anatomy before we get into some of the specific injections. Probably the most common injection we do goes into the epidural space, so you'll see some of the anatomy listed here. The injection begins with the patient lying prone. Usually the skin and subcutaneous tissue is anesthetized with some lidocaine. We penetrate through that tissue, through the supraspinous ligament, the interspinous ligament, through the ligament of flavum, and into the epidural space. The epidural space in the cervical area is only 3 to 4 millimeters thick. In the lumbar area is about 5 to 6 millimeters thick. So it's not a good time once we enter that space for the patient or the physician to sneeze. So we discourage sneezing and coughing. That can be catastrophic. Other than that, it's a very safe procedure. And once into the epidural space, we usually verify our space with some x-ray dye, which I'll show you a picture of here in just a couple of minutes. How do we work patients up for an epidural steroid injection or for any spinal injection? And much like Dr. Dixon said, you can learn a lot from the patients and come up with a pretty good treatment plan just by listening to them and taking a real adequate history. We have them complete a pain diagram so that they can actually put down on paper, and we can document where exactly their pain is. And we try to get them to be as specific as possible, and that really helps us try and put all the puzzle pieces together. As Dr. Dixon said as well, we have to correlate the patient's symptoms with any diagnostic studies that we have available in order for us to determine whether or not we can help them with an injection. Physical examination, again, we're looking for evidence of weakness, which creates a little bit more of an urgency for more interventional treatments, possibly. Reflexes or asymmetric reflexes. If diagnostic tests are available, we love to correlate the findings in the physical examination with that. We don't need diagnostic tests in order to do injections, but they are helpful if they're available. If a spinal injection is found to be indicated, then we start the planning process and the scheduling process. And in today's world, it seems like so many of our patients are on anticoagulation, so that's a big part of how we begin planning if somebody hasn't been found to be a candidate for an injection, is we need to discontinue any anticoagulation. So specifically, and most importantly, any prescription anticoagulation needs to be stopped. Plavix, Ortho, Coumadin, those kinds of things for all patients. And then for those patients that are having cervical injections, we also have them stop any over-the-counter anti-inflammatory medications. Advil, Motrin, ibuprofen, even aspirin for up to 7 days. All of our procedures are done in a sterile environment in a procedure room. Patients are in a hospital gown. Most of the procedures I'll talk about today, the patients are lying supine. They're lying prone. We use a sterile drape, we use a sterile prep, we use an x-ray machine, which is extremely important. And I think that's another very good question for us as providers and you guys as therapists to, when you're taking your history to determine when patients had an injection, make sure that you know whether or not it was done with an x-ray machine. That'll help you kind of have some confidence as to whether or not we know for sure we got the medication in the right spot. We use an x-ray dye to verify the position, numb up the skin, and then proceed with the injection. Typically in the procedure room, we have the physician, an x-ray tech, and usually a nurse available for the patient. Some places, including ours, do offer IV sedation during the injection. Most people don't need it, but for those people that have significant anxiety, we can start an IV and give them a little, I don't care medication, I call it, or we put them in Hawaii for a little while. And that seems to help. What are the most common spinal injections, or at least the ones we're going to cover today are listed here. Interlaminar epidural steroid injections, transformable epidural steroid injections. Those are the most specific ones that I think that provide the most help with patients. Caudal epidural steroid injections. We'll talk about some treatment of facetogenic pain, which involves some diagnostic blocks called medial branch blocks, and a further treatment for facet problems, which includes radiofrequency or rhizotomy procedures. Interlaminar epidural steroid injections is a more general injection. It's probably the most common injection that we do. And as the name implies, it goes in between the lamina into the epidural space and is helpful in patients who have disc herniations with radiculopathy, spinal stenosis, low back pain, leg pain, maybe that patient that has multi-level disease, or maybe that patient that has a non-dermatomal pain pattern. So here's a good example of somebody that may benefit from a lumbar epidural steroid injection. As you can see on their pain diagram, they have somewhat non-dermatomal pain, both back down the back and the front of their legs, and on the MRI scan have multi-level disease. So in the absence of somebody who may be looking for some diagnostic information, or a surgeon looking for some diagnostic information, surgically this patient would probably benefit from a basic straightforward lumbar epidural steroid injection. So we prepare the patient for that, walk them back to the procedure room, lie them on their tummy, and do the procedure as you see here. We use an epidural dye, a radio-opaque dye, to confirm our position. And as you can see, that dye travels quite a distance, so we can cover more than one level with a straightforward lumbar epidural steroid injection. In that patient that has multi-level disease, this is a very helpful injection. Once we've confirmed our position by injecting the epidural dye, that's followed with the steroid medication mixed with some numbing medication and sometimes some normal saline, just to increase the volume and the flushing ability of the injection. Same thing can be done in the cervical spine. Again, indications for a cervical epidural steroid injection include more radicular pain, sometimes some neck pain. So that patient that has a disc herniation or cervical stenosis will do very well, oftentimes, with the cervical epidural steroid injection. I should also say that many of these injections do apply to the thoracic spine as well. I didn't include that with a lot of these slides, but just for brevity, I've just focused on the cervical spine and the lumbar spine. So this patient has multi-level cervical disease, kyphotic deformity, loss of the normal lordosis, and cervical epidural steroid injection may be indicated for helping pain in this patient. Most of our entry points for the cervical epidural steroid injections are usually between C7 and T1, regardless of the level of pathology on the MRI scan. There's a little more epidural fat at this level, so it makes it safer as an entry point to do the injection. If the dye doesn't spread up to the level of pathology, then oftentimes we'll insert an epidural catheter and push the catheter up to the area of pathology and then do the injection at that point. A caudal epidural steroid injection is another approach. We're back down to the lower spine now. This is a good indicated procedure for somebody that's had prior lower lumbar surgery, either a multi-level decompression or possibly a multi-level fusion, as you see here. Because of the increased risk of dural punctures with injections after surgery, this is a good and safer approach for those patients. As the name implies, it's a lower lumbar injection through the caudal hiatus. We insert the needle there and oftentimes use an epidural catheter there as well, thread it up into the area of pathology, verify our position with the X-ray dye, and then do the injection. Transformable epidural steroid injections. These are the sweeter injections that Dr. Dixon likes and prefers, as these are much more specific, and we tell patients we can get a little more bang for our buck by putting more medication at the site, and usually on the specific side is the pathology. So a typical patient that would benefit from a transformable injection is somebody that's having unilateral and dermatomal pain. Certainly we can do these bilaterally as well, but in a patient like you see here that's got a disc herniation, single level disease, a very appropriate injection, and usually a very effective injection, would be a transforaminal epidural steroid injection. As the name applies, it goes in through the foramen. It's done with the same type of positioning. We just tilt the table a little bit laterally so we can view the foramen. Insert the needle, confirm the position with some X-ray dye, and once we know we're in the right level, follow up with the injection. In the cervical spine, we no longer use steroid when we're doing transforaminal epidural steroid injections, and that's due to some increased risk with particulate uptake in the vasculature causing some strokes. So the only type of transforaminal injection we'll do in the cervical spine is purely diagnostic, or just using Marcaine. Still can be very helpful if we're looking for surgical planning or diagnostic evidence. How do you care for somebody after an epidural steroid injection? Well, really there's nothing much to do differently. We tell patients to to resume their normal activity the day of the injection. We tell them not to do any real aggressive activity for maybe up to a week in hopes that the cortisone effect will be maximized. We have them keep a pain diary and actually ask them to rate their pain at different intervals after the injections. Patients will forget oftentimes what their response to the injection was, so when we have them complete a pain diary, it's a good way for us to keep some information available, and we have them bring that back with them when they come back to see us. We simply encourage them to use ice for injection pain. Oftentimes have them start physical therapy within 7 to 10 days. And I picked that amount of time mainly because it takes about that long, I think, for the injection to reach its maximum benefit, which then I think would allow for physical therapy to be more effective. They can progress per your protocols in physical therapy. And if they haven't received about 80% relief, we'll often encourage them to come back and consider a second injection. We used to give 3 injections when we did epidural steroid injections. We used to give 3 injections 1 week apart, whether they needed them or not. And now we actually stop after 1 injection and kind of grade the amount of improvement they receive. And if it's at least 80%, we stop with 1 injection. If it's between 50 and 80%, we may consider a second injection fairly soon. So that's a good question to ask patients and something you might consider having them return for if they haven't received significant relief. As I alluded to earlier, I think another real valuable tool that we can provide from an interventional standpoint is diagnostic information. And we can do this both with steroid and call it a diagnostic and therapeutic injection, or we can do it just with Marcaine. And this becomes very helpful for surgeons as they're planning which surgery may best benefit the patient. I also think it provides very valuable information to physical therapists. Again, we learn so much based on patients' response to an injection. And if we put numbing medication and some cortisone medication into an area that we think is causing their pain and they don't receive any relief, that's very helpful information, and it might make us want to go look somewhere else to find the cause of their pain. So sometimes the cause of a patient's hip pain looks you right in the eye, like this one. Other times, it could be a number of different things. And these are the types of patients that we see sometimes on a daily basis, where you have on the far left somebody who's had a multi-level fusion, who then we know might be prone to having some adjacent level disease above the fusion at L2-3, or possibly some SI-related pain. This patient on the MRI scan, you can see definitely has some stenosis. I don't have the axial view there, but it's evident that there is some spinal stenosis at the adjacent level above the surgery. And guess what? They also have a little arthritis in their hip. So this becomes somewhat of a diagnostic challenge, and I think the role of interventional treatment here is really substantial. So we can do an injection and rule something in or rule something out based on the patient's response. Another common area where interventional procedures are indicated, or at least can be possible, has to do with facet syndrome. Cervical facet syndrome, lumbar facet syndrome. We all know the causes of this usually involve some type of trauma or some type of repetitive activity. It's usually associated oftentimes with some form of disc degeneration, more common in obese patients and more common in smokers. The pain patterns look somewhat like this, and we see most of the time patients that we help are having more cervicogenic pain and headaches. These patients are very happy if we can provide them relief with some of the procedures that I'll talk about shortly. So remember the pain patterns that you see here for patients that may be experiencing facet pain, both in the cervical spine and the lumbar spine. And if they've exhausted conservative care, including physical therapy, activity modification, weight reduction, they've quit smoking, I wish it was as easy as just saying all those things, then an interventional treatment may be indicated. These patients present with a traditional stiff neck as we talk about cervical spine facet pain. They fail conservative care. Usually they have a history of a whiplash type injury or some type of a motor vehicle accident is a real common history. They may have on their diagnostic studies very dramatic evidence of a disc space collapse and facet arthropathy, or on an MRI scan may have evidence of what you see here, facet hypertrophy and some inflammation within the facets. That makes it pretty easy when we have those things available. Our goal with these patients initially, if we're going to consider something interventionally, is to first diagnose the levels and whether or not we are barking up the right tree with diagnosing facet-related pain. So we do something called a diagnostic medial branch block. And again, we do these in the cervical spine, the thoracic spine, and the lumbar spine. And with this block, we have the patient come into the clinic on a day when they're having their typical pain at a significant level. It has to be, we would like it to be 6, 7, 8, 9, 10 out of 10, which allows us to glean a lot of useful information when we do the diagnostic test. On the pain diagram, it looks very much like this. And again, we want the patient's pain to be at a fairly high level so that when we do this test, we could get a decent response. Cervical medial branch block involves a procedure where we take the patient back to the procedure room and just simply put Marcaine or a numbing medication over those medial branch nerves that supply those facet joints with pain. Oftentimes, more than one level is included. And when we inject Marcaine over those joints or over those nerves, hopefully we're going to give them significant pain improvement, and we have them document that on a post-injection pain diary. We call the patients the next day, and we hope it looks like this, where their pre-procedure pain level was up to an 8 out of 10, and you can see what happens as that Marcaine starts to work. And once again, this is often done at more than one level, and patient's pain goes from an 8 out of 10 to a 4 to a 2 to a 1, and then we would expect as that Marcaine wears off on day 1, day 2, day 3, that the pain will gradually climb up again. We've got to do this procedure twice, so we call the first one a diagnostic medial branch block. We call the second one a confirmatory medial branch block. On both of those diagnostic tests, we again have to see very significant improvement in the patient's pain. And again, it's only Marcaine that we're using, so it's temporary. But if we see these results twice with a diagnostic and a confirmatory medial branch block, we can do a procedure called a rhizotomy or radiofrequency ablation. And this simply involves placing a heatable probe over those medial branch nerves, hooking it up to a machine that creates radiofrequency. We burn those nerves, which kills the pain response of those nerves and gives the patient's pain relief sometimes up to 6 to 9 months. So it's a much more effective way and a more long-term way to control patients' pain that may be coming from their facet joints. And again, this is commonly done in the cervical spine, lumbar spine, not as common in the thoracic spine. Care after a rhizotomy, these patients may be a little sore for up to 2 weeks. Sometimes they complain of a burning type pain. It almost feels like they have a sunburn. They can return to regular activities the next day. They may not be ready for real aggressive physical therapy for a couple of weeks, but they can certainly start some gentle range of motion and some stretching exercises fairly quickly. In summary, when to consider an epidural or an interventional pain referral? I think in the acute setting, anytime you've reached kind of a roadblock when you're caring for patients, patients whose pain hasn't improved after roughly 6 weeks of conservative care, I think maybe a patient we would consider doing an injection on. Other times in patients where you've again reached a roadblock and what you're doing is not working, that patient that's had pain for a long period of time and physical therapy just isn't giving them any relief. The presence of weakness, I think, is a great opportunity to consider something interventional. Patients who have had persistent night pain or interruption in their work activity, quality of life becomes a big issue, and I think when that's becoming affected, it may be time to consider an interventional pain referral. Or when you're looking for some diagnostic help, information because you're not quite sure where the pain is coming from. I think it's a great idea or a great time to consider an interventional pain referral. Thank you.